most of the time in ICU you don't have that short period bronchoscopy because you need to really look at it what is happening. So you need to be little time consuming. So in that case you should have this. This is the valve from where you will open it and introduce the scope. The utility of this valve is that only minimal loss will occur. This valve can completely open it and show that. Yeah. This is the opening from where you can do. If you see it closely, it is nicely nugged and it is of the size where the bronchoscope will just fit in there. So loss of tidal volume will be very minimal. You remove the whole of it. You can remove the whole thing and introduce the scope. But now you see there's a complete loss of the tidal volume. This is the extension tube which is being attached, right? One thing he told you more was try to reduce the length of the tube outside, because maneuverability of a bronchoscope, the longer is the length of the endotracheal tube, difficult it is. And since you cannot do anything more than that, what you do is that the moment he puts in a scope inside, 8.5. Always more than 8 is to be preferred. Don't try to do it in less than 8, hypoxia will be more, right? But in female sometimes you have to put in 7.5 and do it, but then 4.8 will only go. 6 millimeter or 5.9 millimeter which we are using will not go. In fact 9 is a preferred one here, and this kind of a patient can very well take 9 also. And he could be in fact changed the tube also prior to doing the bronchoscopy. So if you are not comfortable with the size, you have to tell the anesthetist to change the tube. And the tube should be minimum 8, 8.5 or 9 preferred. Sometimes these people can put in 9.5 tubes for us to be doing lavage and other procedures and go again and again and do it. That is an easier. Tube is there, connector is there. We try to reduce the size of the tube because we have to negotiate less amount of distance. And it is, you have to go through this, and then obviously airway resistance will be becoming high with that. This kind of thing which you are seeing is easily available, and in the ICUs they are there. You have to just use it. We are reusing it every time we are basically ETO, send it for ETO, and then we are reusing it. Scope lubrication is, as I told you, is very important because it has to slide through this, and it invariably is a dry one, and it will be getting stuck onto the walls of the endotracheal tubes. To make your passage smooth, this is the way you are supposed to go. You have your monitors there. The anesthetist is looking at the monitors. Your job is to look at the bronchoscopic monitor. He is supposed to maintain the vitals. We are starting with a little tachycardia. Why is this tachycardia there? Why is the tachycardia there? No, what is it? It's inadequate sedation, or what is it?
Well, what happens is that
primary disease.
Primary reason. He's had a tachycardia because when he was moved over here, his heart rate was 1 or 200. He has got that.
Yes, it's 122. Bronchodilators and aminophyllins must be there because he is having a COPD. Now what I'll do is I'll auscultate and see. I don't find any expiration prolonged or wheezing. I don't find anything. So I don't find this is the reason. Had this, as he would have told you in complications, if they have already severe bronchospasm, you do it, it will precipitate more bronchospasm. And what it will happen is when there is so much of bronchospasm coming, the cardiac output will fall, hypotension and bradycardia will occur. So to prevent that, you will just see that not severe bronchospasm. If there is, nebulize the patient before doing bronchoscopy. Otherwise, I would have said, okay, first nebulize this patient, then only we'll take the patient to bronchoscopy. Go ahead, introduce this. This you can do it from this side also. You don't have to be on the head end. But only thing is, since you know your anatomy, that is fine. Now when you're looking at the endotracheal tube, it is a blue line which is going to tell you on what side you are. Right? There is a line, blue line. And that blue line will tell you where you are. Major reason about volume control is that volume is guaranteed. The difference between volume and pressure you all know. Pressure is guaranteed, volume is guaranteed. Now when volume is guaranteed, even if there is an increase in pressure, same amount of volume will definitely go. So patient will not have hypoventilation because of the low tidal volume. So that is why volume is always controlled. Now you look at these waveforms, his peak pressures are only 21 at the moment. Fine, 20, 21 is very good, he's doing. And With this preparation on the ventilator, we go to our bronchoscopy. Now, the most important thing when you introduce this, first thing is to lubricate this very nicely. Because the major injuries, you are at the back, you can come on the sides. Please give the space, COPD patient. So there must be auto PEEP in that patient. So that is why they have kept it like that. PEEP is fine. Salik told you that you don't want to do in a patient who's on a PEEP like 10, 15 or something like that. The reason being that the moment you are going to disconnect, the PEEP is going to go off, finish. So whatever was the improvement in oxygenation because of the PEEP will go away. So patient will develop suddenly more hypoxia. So higher is the PEEP the patient is on, more will be the loss effect on hypoxia. You don't want that. That is why if this patient had been on 15 PEEP, I would have brought him to 10 in the 15 minutes time, seeing how the things are going on, and then if his saturations are fine, no tachycardia, heart rate is fine, I would bring down this PEEP to 10, and then from 10 onwards I can disconnect and do no problem. Here it required 5 because maybe his auto PEEP was only 5. Max pressure, this is the maximum pressure which is allowed is 40, because if you go above 40 then obviously the blast can be there and barotrauma, you told it, patient can develop pneumonia. Because the moment you put in your scope, there will be an additional thing in the airway, it will work more like increasing the pressures. That is why the airway, it showed you peak pressures rise.